So, these are my topics which I'm going to cover. Introduction about coming to the introduction. Atherosclerosis is one of the most complex of all disorders with multiple genetic and environmental contributions. One of the major genetic factors, the family history, is the most significant independent factor. The familial of the diseases, that is familial hypercholesterolemia, familial hypertension, diabetes, and obesity. These multiple heritable and genetic many cases in families. So it's not only the genetic factors which play a role. There are other factors like the epigenetic factors which are apart from the genetics, and also the environmental factors which play a major role in development of all these familial diseases. Most of the clinical atherosclerotic diseases result from interaction of multiple genetic factors, none of which usually cause disease. Yeah, by itself. Disease in which the plaque builds up inside the artery wall, causing thickening and narrowing of arteries, thereby reducing blood supply to end organs. There are non-resolving interactions of inflammation, oxidative stress, lipid deposition, and genetic predisposition. When there is imbalance between arterial damage and repair, it leads to atherosclerosis. This image on the right-hand side shows. It's just an image which shows when there's altered tissue hemostasis, what is going to happen. So when there's endothelial damage, there is vascular inflammation. So once there is vascular inflammation, there is decrease of non-functional stem cells, which leads to injury and disease. Whereas on the right side, there are signals to mobilize the bone marrow. And in healthy and sufficient functional stem cells, the repair happens. Whereas if the inflammation is increased, it leads to disease. So there's always a tissue hemostasis which balances between health and disease. When the tissue hemostasis is lost, that is when repair is not able to be done, then only there occurs the disease. So atherosclerosis is a disease where there is a defect in the hemostasis more than the disease of genetics. Okay, familial hypercholesterolemia is a inherited metabolic disorder characterized by severe hypercholesterolemia due to accumulation of LDL in the plasma, with cholesterol deposition in tendons, occasionally in skin, and an increased risk of premature atherosclerosis manifesting almost exclusively of precocious coronary artery. So on the image on the right side, which just shows what are the features of hypercholesterolemia. That is coronary artery disease because of atherosclerotic deposition, then xanthelasma arcus, and also xanthomas of the tendons. This image is not clear. Sorry for it. It's a familial hypercholesterolemia is again divided into autosomal dominant and recessive, and among which autosomal dominant is the most common one. In the autosomal dominant one, there is again heterozygous familial hypercholesterolemia and homozygous familial hypercholesterolemia. The heterozygous familial hypercholesterolemia is a less severe variant, where there usually presents with atherosclerosis and CVD, whereas in the homozygous familial hypercholesterolemia, a patient presents with also presents with other diseases, including xanthomas and corneal arcus. The main mutations are LDL receptors ApoB, PCSK9, and LDL receptor adaptive protein 1. I'll be explaining about them. Okay, this is just about cholesterol metabolism. I mean LDL metabolism. Normally, LDL in the body is it has all lipid lipoproteins. LDL, the main LDL is present on the surface. Before that, coming to the synthesis of LDL, you can see a of the reticular LDL receptor and the gallbladders. So after synthesis, with the help of the PCSK9. So once it reaches the surface, LDL receptor binds to LDL, and it is internalized via the clathrin coated pits. That is the main gene responsible is LDL receptor adaptive protein 1, which which when there is defective LDL AP1 leads to autosomal recessive hypercholesterolemia. So once there is internalization, there is dissociation of the ligand receptor complex in the endosome. So once there is dissociation, LDL is separated and LDL is degraded in the lysosome. So there is a sterile mediation regulation of transcription of LDL receptors and enzymes involved in cholesterol synthesis. So once again, when the LDL receptor is out of the endosome, it is again recycled to the basolateral surface with the help of PCSK9 gene. Okay, again, the genetic pathogenesis of familial hypercholesterolemia, the main genes which include the LDL receptor, PCSK9, ApoB100, and autosomal recessive hypercholesterolemia because of LDL receptor AP1 gene. So LDLR, PCSK9 and ApoB100 leads to autosomal dominant hypercholesterolemia, whereas ARH leads to autosomal recessive hypercholesterolemia. And the percentage LDL receptor is about 69% of all the mutations which are seen in familial hypercholesterolemia. The rest are less. This is the genetics of hypercholesterolemia about heterozygous and homozygous. When you see the label A, it is when a heterozygous female and a heterozygous male in the pedigree chart give birth to give offsprings. Then usually there is about only 25% of patients likely to develop homozygous familial hypercholesterolemia, and 50% of the patients develop heterozygous familial hypercholesterolemia, and 1% is a normal subject. So the genes, the chromosomes which code for these genes are chromosome 1 for LDL, RAP1 and PCSK9, and chromosome 2 for ApoB, and chromosome 19 for LDL receptor. Okay, and the difference between heterozygous familial hypercholesterolemia and sorry, there's some problem. Yeah. Yeah, the clinical manifestations of homozygous familial hypercholesterolemia and heterozygous familial cholesterolemia is there is xanthomas in both, and cutaneous xanthomas are more common in homozygous, and the incidence of coronary disease is more severe in homozygous, and it is seen in very less age, that is less than 25 years of age, and LDL cholesterol levels are usually very high in case of homozygous familial hypercholesterolemia, that is more than 12 millimoles per liter. So coming to the lower image, the heterozygous familial hypercholesterolemia, it's usually one allele which is defective, whereas in homozygous it's both the genes, like I showed you in the previous pedigree chart. The cholesterol LDL levels in heterozygous is more than 190, whereas in homozygous it's more than 400. The coronary heart disease onset is mostly in childhood in homozygous, whereas it is usually seen in adult or late adulthood in heterozygous. Most respond to drug therapy in heterozygous, whereas there's very poor response in homozygous familial hypercholesterolemia, and it's very heterozygous is very common. It's seen in 1 in 250 of the patients. Okay. Coming to the mutations of LDL receptor, which is the most common, accounts to about 67% of familial hypercholesterolemia. There are 6 classes of defects, which are 6 classes which have been described. It basically these 6 classes are the genetic abnormalities which happen during the cholesterol, the LDL synthesis or the LDL metabolism. Coming to class 1, this image, class 1, it's defective in receptor synthesis. So here in class 1, the receptor itself is not synthesized. In class 2, the receptor which is has to be transported from the endoplasmic reticulum to the Golgi apparatus doesn't happen. So there is impairment of the LDL receptor which reaches to the basolateral membrane of the cell. Then class 3 is LDL binding by the receptor. So LDL receptor is normally synthesized, but the binding of the LDL doesn't happen to the LDL receptor. And class 4, there is receptor clustering in the pit. So the LDL binds to the LDL receptor, but it doesn't enter. There's internalization is impaired. And class 5, after internalization, there's failure of the discharge of LDL in the endosome. So there is no recycling. And in class 6, the LDL receptor which has come out of the endosome cannot be retransported to the basolateral surface. So this is the 6 classes. Coming to the second gene mutation, that is ApoB100 mutation. Sorry about the image. ApoB100 mutation. There are very few mutations which have been described about ApoB100 mutations, and individuals with heterozygous familial binding defect ApoB100 exhibit cholesterol levels of about 300 due to defective LDL clearance. And in homozygous, there appears to be no significant gene dose effect. Coming to the third gene mutation, the PCSK9 gene mutation. PCSK9 protein binds to LDL receptor and induces LDL degradation. PCSK degrades, like I've explained in the first, the PCSK role of PCSK. PCSK degrades LDL receptor by preventing the hairpin conformational changes of LDL receptor. Then reduced LDLR levels result in decreased clearance of LDL, which can lead to hypercholesterolemia. And coming to mutations in the autosomal recessive hypercholesterolemia, this is the adaptive protein, that is LDLR AP1 protein. Here there is defect in internalization of LDL receptor. So there's disruption of LDL receptor endocytosis in some familial hypercholesterolemia patients, affecting the clearance of LDL by liver, and therefore responsible for homozygous familial hypercholesterolemia phenotype. To familial hypertension. Hypertension familial and is likely to be the consequence of interaction between genetic and environmental factors. Variance in blood pressure readings is about 30 to 50% due to the genetic inheritability, and 50% is environmental factors. So it's not only the genetic inheritability that is causing the disease; it's more of the environmental factor which contributing to the common forms of hypertension are like unknown. The genetics of hypertension is complex, with no single gene playing a major, rather many genes, each with mild effects reacting to different environmental stimuli and thus contributing to elevated blood pressure. Okay, the are involved in familial hypertension are the RAS system, controlling blood pressure in salt, the systems which control the blood pressure in saltwater hemostasis, regulation of blood pressure, that is enzyme receptors of the mineralocorticoid and the glucocorticoid pathways, and proteins coded by genes involved in structure or regulation of vascular tone, that is the endothelins and the receptors. So these are the four genetic problems which can occur in a familial hypertension patient. So when there's a stenosis, say a renal artery stenosis, or when there's a hypotension, what happens is the renin is secreted from the JG cells. Once the renin is secreted, it acts on the angiotensinogen, which gets converted to angiotensin 1, and angiotensin 1 in the lung gets converted to angiotensin 2 with the help of ACE angiotensin converting enzyme. So once the angiotensin 2 is released into the circulation, the various effects which happen are vasoconstriction, renal sodium retention, aldosterone secretion, and vascular effects like hypertrophy, remodeling, endothelin release, prostaglandin synthesis, and oxidative stress. And there is sympathetic nerve system activation, which again leads to vasoconstriction, and myothelial effects like LVL, left ventricular hypertrophy, myocyte growth, and left ventricular remodeling. Coming to the familial diabetes, coronary vascular disease is more prevalent in type 1 and type 2 diabetes and is the leading cause of death among with diabetes. Type 2 diabetes, commonly referred to as insulin resistance, is partly inherited, and insulin resistance is associated with enhanced generation of reactive oxygen species, reduced nitric oxide production, increased release of free fatty acids from adipose tissue, which impair endothelial function and induce growth, low-grade inflammation. And hyperinsulinemia, what are the effects of hyperinsulinemia? They include, they augment the VLDL synthesis in liver, they increase cholesterol transport or synthesis in cultured arterial smooth muscle cells, stimulates the proliferation of arterial smooth muscle cells, it augments collagen synthesis and turns on multiple genes in inflammation. Although insulin are expressed on endothelial cells, vascular smooth muscle cells, and macrophages, but the mechanism in which it contributes to the vascular pathology is still unknown, and also the metabolic resistance pathology is really unknown based on these receptors. So diabetes susceptibility locus for non-insulin dependent diabetes, chromosome 2q, and second locus for diabetes is chromosome 1q. The genome wide association study and linkage analysis, they have identified about more than 120 genetic variations associated with type 2 diabetes. Many of the variants identified to date regulate insulin secretion, insulin action in insulin sensitive tissues. Coming to familial obesity, obesity is a major contributor of coronary disease and cerebrovascular disease and mortality. It exhibits considerable metabolic overlap with abnormalities present in type 2 diabetes. It's associated with other cardiovascular factors such as hypertension, hyperlipidemia, and insulin resistance. So it's basically a cocktail of everything. So familial obesity is always usually associated with hypertension, hyperlipidemia, and insulin resistance. It's a complex disease resulting from interaction of wide variety of hereditary and environmental factors like all the familial conditions. The genetic involvement in obesity suggested is suggested by the clustering of cases within a family, the congruence of body weight in monozygotic twins, and discovery of genes associated with obesity. So these are the three factors which can tell that there is some genetic involvement in obesity. So obesity risk is 2 to melanocortin pathway, leptin and its receptors. I'll just explain about this later, and the other genes. So what happens? Leptin is released from adipose tissue. So this leptin, so in the hypothalamus at the arcuate nucleus, it activates POMC. Also, it inhibits NYP, the neuropeptide Y hormone. So what happens once the POMC is activated? There's increased alpha MSH, which basically reduces the appetite and causes early satiety and also increases lipid metabolism. And neuropeptide Y also is an inhibitory protein. So in neuropeptide Y also, because of inhibition of neuropeptide Y, there's also similar action like reduced appetite, increased satiety. So coming to the genetics of peripheral arterial disease. So peripheral arterial disease is a distinct subtype of atherosclerotic vascular disease that differs from CAD and CVD in its clinical manifestation. But the reasons are not very well understood. The main thing in CAD and CVD is thrombus formation, which occurs very acutely. But whereas in a peripheral arterial disease, most of the disease is moreover chronic, and there is progressive arterial narrowing because of the ongoing atherosclerosis. So difference between CAD and CAD. Risk factors are both genetic and environmental, and the intermediate biochemical pathways through which they contribute differently to PAD than CAD and CVD. PAD is complex and heterogeneous, and there are two broad subtypes, which is proximal and distal, as we all know. Proximal disease is more common in females, smokers, hypertension, dyslipidemia. Distal disease is more common in diabetics, older age, and male sex. The candidate genes include the B fibrinogen, ApoB, endothelial nitric oxide synthase, G protein, beta 3 alpha adducin, IL-6 glutathione S transferase. However, any reported association between variation in these genes and PAD have not been confirmed. Genetic analysis do not appear to be useful in CAD in determining progression of the disease. Similar to CAD, several Mendelian disorders are associated with PAD, which include familial lipoprotein disorders such as chylomicronemia, familial hypercholesterolemia, hyperhomocystinemia, and pseudoxanthoma elasticum. Non-genetic factors include now generally considered that atherosclerosis results from a variety of genetic causes with added epigenetic modulation and interaction of genetic and environmental factors. So there has to be a genetic cause with added epigenetic modulation, that is post transnational or transcriptional modification, and along with environmental factors. None of these triggers is sufficient to cause atherosclerosis on its own. These are just how it happens. Initiation of a lesion, it's because of inhibition of VCAM1 gene, that is vascular cell adhesion molecule gene expression. Then there is a progression of lesion because of expression of vascular smooth cells protein and osteogenesis, and plaque complication. There is exposure of subintimal thrombogenic substances to the bloodstream. Environmental factors. The genetics of atherosclerosis induced CVDs involve a large number of genes having weak effects on disease risk, but possibly interacting with each other with environmental factors could act synergistically in the pathogenesis of atherosclerosis and its complication. Gene environmental interactions can be either complementary or antagonistic. Complementary gene activation interactions may play a substantial role in CAD risk, that is high risk genetic profile, high risk environmental, which leads to premature coronary artery disease. The environmental factors which are involved in premature PAD, that is smoking, sedentary lifestyle, and unhealthy diet, and also certain viruses which have a role. Coming to the epigenetic factors, epigenetics refers to changes in gene expression resulting from factors other than direct change in DNA sequence of the genome. Epigenetics represent a critical link between genome coding and phenotype expression that is influenced by both underlying genetic and environmental factors. Epigenetic modifications contribute to subclinical and clinical CAD, CVD, and PAD. Now, what are the epigenetic mechanisms that happen are DNA methylation, post-translational histone modification, and post-translational modifications such as small non-coding mRNA. Now, this is an image which shows epigenetic modification. So, if you see the lowermost part of the image, when there is a genetic and the environmental interaction, there are epigenetic modification which happen in the nucleus and in the mitochondria as well. So epigenetic genetics which happen in the nucleus, there is DNA methylation. Once there is DNA methylation and there is transcription of this DNA, which enters in after transcription of the DNA, it enters into the cytoplasm where mRNA is synthesized. Because of the gene mutations here, there's production of this antisense epigenetic mechanism like miRNA, and also there's post-translational modification which leads to protein synthesis, but an abnormal protein synthesis which leads to peripheral arterial disease. Coming to risk assessment and diagnosis. Hypercholesterolemia, the diagnosis of both homozygous and heterozygous is based primarily on the finding of severe LDL elevations, absence of secondary causes of hypercholesterolemia. So the secondary causes have to be ruled out to diagnose this. So these are diagnostic criteria for familial hypercholesterolemia. Coming to the family history, there should be premature coronary artery disease, that is more than 55 years in men and less than 60 years in women among first degree relatives, and more than 95 percentile of age and gender in first and second degree relatives. Clinical history, patient with premature CAD or CVD, and in laboratory examination, there should be high LDL levels, more than 250 in adult and more than 200 in patients less than 20 years of age. And on physical examination, there should be tendon xanthoma, arcus cornealis, and in genetic testing, there should be LDL receptor ApoB and PCSK9 gene mutation, and there should be no secondary causes of hyperlipidemia. That is normal liver enzymes, normal renal function, normal thyroid hormones, no hyperglycemia or albuminuria. Coming to homozygous familial hypercholesterolemia, there should be in homozygous familial hypercholesterolemia, there is severely elevated cholesterol levels, like I discussed earlier. That's about more than 600, and triglyceride levels remain within normal range. A substantial increase in serum triglyceride levels should raise the possibility of another lipid disorder. Heterozygous familial hypercholesterolemia, if the LDL levels is commonly greater than 250, then heterozygous is suggested. In patients less than 20 years old, an LDL level greater than 200 is suggestive of heterozygous or possibly a familial ligand defective ApoB100. In adults, LDL levels greater than 300 suggest heterozygous, and if tendon xanthomas are present in patients with LDL level above 95 percentile, a probable diagnosis of heterozygous familial hypercholesterolemia can be made. A careful family history is essential for comprehensive assessment of possible familial hypercholesterolemia in general and homozygous patients. In particular, in the cases of autosomal dominant mutations, parents are obligate heterozygotes, and therefore display elevated LDL levels, and strong positive family history of premature cardiovascular events. Okay. A definitive diagnosis can be made only with gene or receptor analysis. The genetic diagnosis is popular PCR for LDL receptor and ApoB defects. Only a few mutations are known in ApoB, but there are more than 750 mutations noted in LDL receptor mutations. That is about which accounts for the maximum of familial hypercholesterolemia. There are new technology for diagnosis, that is the next generation sequencing and the RNA sequencing. Cell cultures is more reliable in identifying LDL receptors defects. It is worth considering plasma phytosterols for phytosterolemia and cholesterol for cerebrotendinous xanthomatosis, and investigating the genes influencing the concentration of these products. Coming to familial hypertension, familial history and genetic markers again are very important in the workup. Familial history of hypertension is as common in hypertensive population than in those with normotensives. The genetic factors include inherited defect in cellular sodium transport. Other factors to be investigated include type 2 diabetes, dyslipidemia, BMI, sex, age, smoking, psychological factors, which all play a contributory role in the development of the disease. The laboratory genetic tests include the angiotensin, ACE, and alpha-adeusin genetic testing. Coming to the familial diabetes, in most patients of type 1 diabetes, people must inherit risk factors from both parents, and many people, the development of type 1 diabetes seems to take many years. Early onset suggests a major role for genetic factors with a strong inverse association between age at diagnosis and prevalence of HLA alleles, conferring the susceptibility. So, in whites, HLA-DR3 and HLA-DR4, and Afro-Americans, it's HLA-DR7, and Japanese HLA-DR9, which are the most common genetic HLA mutations which are noted. Individuals with at high risk can be identified using immunologic, genetic, and metabolic parameters. In addition, circulating antibodies to pancreatic beta cell antigens are markers of islet autoimmunity. Type 2 diabetes accounts for about 90% of all cases. It has stronger link to family history and lineage than type 1 diabetes, although it also depends on multiple environmental factors. Type 2 diabetes tends to run in families based on sociological and genetic factors. In general, the lifetime risk of developing the disease is about 40% in offspring in one parent of type 2 diabetes, greater if the mother is affected, and approaching 70% if both the parents have diabetes. So patients with certain rare types of type 2 diabetes have different risks. In patients who have maturity onset diabetes of young, their child has 50% chance of getting it. Coming to familial obesity, obesity tends to run in families, hence the family history is a basic tool assessment. BMI is the most common way to estimate body fat based on comparing a person's weight to height. Body fat can be measured in other ways, like waist circumference, waist to hip circumference ratio, skin fold thickness, and ultrasound, which are more precise than BMI. Defined differently for children and teens than adults. Children are still growing, and boys and girls mature at different rates. So the location of fat deposition, variation in secretion of adipokines, and other factors govern whether a particular obese person is more predisposed to obesity-associated diseases and thus is at risk. So physiologically, metabolically deleterious and life-threatening forms of obesity are associated with preferential accumulation of fat in the visceral adipose tissue, with ectopic fat deposition in insulin-sensitive tissues such as muscle, liver, and pancreas. So this is deposition of fat in the visceral adipose tissue and in these insulin-sensitive areas are more deleterious. This aberrant fat content strongly correlates with severe generalized insulin resistance and the development of chronic inflammatory state, partly due to infiltration of adipose tissue by macrophages. An anti-inflammatory adiponectin is known to strongly modulate the risk of metabolic and type 2 diabetes associated with obesity. Variation within the adiponectin gene is reported to modulate plasma adiponectin levels and also to predict diabeticity and associated CADs. Paradoxically, the adiponectin variant alleles that protect against the development of diabetes by maintaining high adiponectin concentration are also associated with obesity risk in both adults and children. Individuals with high adiponectin levels can be severely obese but seems to enjoy the metabolic protection. So these people will be obese, but this adiponectin tends to protect these patients from CAD. The same alleles, together with type 2 diabetes protective PPAR gene associate with CAD protective risk factor pattern, elevated adiponectin and insulin sensitivity, but also with a dramatic increase in 3 units of BMI. Biomarkers have been used for assessing developmental of obesity and its sequelae. However, the value of these biomarkers in risk assessment remains limited. The markers include ACE, AGE, alpha ketoreductase family 1 member, and B10, alpha methyl CoA racemase, and there are multiple genes which are involved. Risk assessment, risk management. Okay, this is the most important part. The risk management, familial hypercholesterolemia. If they're diagnosed and treated early in childhood, individuals with familial hypercholesterolemia can have a normal life expectancy. So, early treatment of familial hypercholesterolemia, what does it do is it reduces the LDL burden, improves the endothelial function, and attenuates the progression of atherosclerosis. So, children with heterozygous familial hypercholesterolemia, again, homozygous familial hypercholesterolemia is more severe, just to reiterate, like what I've told in the earlier slides, and heterozygous is a little less severe. So, children with heterozygous familial hypercholesterolemia should be treated with fat modified heart healthy diet at diagnosis, and they have to be started on statins at the age of 8 to 10 years. Now, what are the foods which I have to avoid is basically the junk foods, and what are heart, like I said, the heart healthy diet, fat modi include and these almonds, walnuts, which are high in protein and less carbohydrate rich food have to be taken. Um, what is the heart healthy diet? This is the thing the patients have to be advised. They have to eat adequate fruits and vegetables, variety of grain products every day. Eat fish at least twice a week. Limit saturation fat and cholesterol. Read food labels. Limit the amount of trans fat. Choose healthy fats. That is better to avoid saturated and trans fats. Eat only small minimum. Only many calories as you need. Don't overeat. If you moderate alcohol consumption, limit sugar use. And how does it work? Is it just works similar to statins and ezetimibe and PCSK9 inhibitors by increasing the number of LDL receptors on the liver surface and thereby reducing the LDL levels in the body. As we all know, three types of fat: saturated, trans fat, unsaturated fats are there, which are healthier, where consume diet unsaturated like nuts or food rich in omega 6. The current diet recommendations for familial hypercholesterolemia are to eat less than 7% of the total fat from saturated fat, and to replace the saturated fat with unsaturated fats, protein, or carbohydrates. For children aged 8 to 10 years, it is recommended to reduce the LDL by 50% from pre-treatment levels. And for children above the age of 10 years, especially if there are additional cardiovascular risk factors, including elevated lipoprotein, the target LDL should be less than 3.5 millimoles per liter. That is about 130 mg per deciliter. In homozygous familial hypercholesterolemia, pharmacological treatment should start at diagnosis. Cholesterol containing foods without saturated or a trans fat may be allowed. Physical activity should be promoted, and smoking is strongly discouraged. Coming to pharmacotherapy of hypercholesterol, statins, the various drugs which have been used are statins, which inhibits HMG-CoA reductase, thereby reducing the LDL levels. Ezetimibe, which inhibits cholesterol absorption. Bile acid sequestrants, which reduce cholesterol pool in the cells by reducing absorption. The other modern pharmacotherapy agents they used in which achieves desirable concentration of LDL in heterozygous patients, but in patients of homozygous hypocholesterolemia, still controversial and not well understood. So, with the various drugs are mipomersen, which is a ApoB antisense oligonucleotide, and lomitapide, which is a microsomal triglyceride protein inhibitor, and PCSK9 inhibitors like the evolocumab and alirocumab. Surgical options are also liver transplantation, which is mainly considered for patients with homozygous familial hypercholesterolemia. But again, there are various complications related to the transplantation, and the partial ileal bypass and portal shunting, but is not recommended nowadays. Coming to the gene therapy, this is used to correct defective genes. For example, replacement of LDL receptor genes have has the potential to decrease LDL levels, while also making patients with homozygous familial hypercholesterolemia more responsive to conventional therapies. So this is the image which shows patient with this image with patient with a coronary artery disease. This hepatocyte is taken for culture. This hepatocyte is grown on a culture media. Once it is grown, this is a hepatocyte which is infected with a retroviral vector. So this retroviral vector is contains the cDNA, which required, uh, which is transported within, which is which is incorporated into the vector, and the hepatocyte is infected. So once the hepatocyte is infected, the hepatocyte carries the cDNA from for the LDL receptor synthesis. So once there is transcription and translation and post transcription modification, there is a functional LDL receptor gene which is formed within the hepatocyte. This hepatocyte is regrown in the culture media and infused back into the patient. So this seems to have it's in the research process and seems to have a promising result. Coming to the familial hypertension, treatment of familial hypertension should come with lifestyle modification, pharmacotherapy. The best strategy is to formulate a combination therapy that targets different physiological mechanisms and accounts for patient comorbidities. The primary aim of antihypertensive treatment is to reduce the blood pressure to less than 95th percentile and to less than 90th percentile in presence of comorbid conditions like diabetes, heart disease, and kidney disease. What is the lifestyle modification? Weight reduction, reduce salt consumption, and this is the DASH diet which has to be followed. What are the drugs which include in the DASH diet are fruits, vegetables, whole wheat grains, whole grains, healthy dairy, lean meat, nuts, seeds, legumes. Whereas what are the foods to be avoided, which has to be advised to the patients, are sugar products, full fat dairy products, increase salt, alcohol, and there should be moderate consumption of alcohol, and regular exercise. Okay, now what are these lifestyle modifications tend to reduce this? What is the how much of the blood pressures can these reduce? So weight reduction reduces about 5 to 20 mmHg per 10 kg loss. The DASH diet eating plan can reduce 8 to 14 um, mmHg of blood pressures. Reduced dietary sodium can reduce blood pressures about 2 to 8 mmHg. Physical activities again to 4 to 9 mmHg, and moderate consumption of alcohol reduces blood pressure by 2 to 4 mmHg. The pharmacological therapy for guidelines for treatment of essential hypertension. So patients who are more than so how do we start antihypertensives for these patients? So patients who are less than 55 years, it's better to start them on ACE inhibitors or ARBs. Whereas patients who are more than 55 years, the first line of drugs should be calcium channel blockers. So if they're not responding to them, you can add thiazide diuretics next. If thiazide diuretics, if blood pressure is still not getting under control, then you can add spironolactone as a fourth line drug. And fifth line drug is again vascular specific or the cardio specific beta blockers like the carvedilol. Still, it doesn't come under control. Then there are various other options like alpha blockers, clonidine, methyl dopa, direct vasodilators like hydralazine and minoxidil. Adequate monotherapy controls hypertension in only 30% of cases. If monotherapy is insufficient, it should be modified by altering or adding a drug. Therapy must be optimized before selecting further therapy because optimal dosing and drug selection can see blood pressure normalize in many patients. Patients must be approached in a stepwise manner, beginning with traditional antihypertensive therapy, followed by gradually adding agents. In those who remain hypertensive despite thorough medical management, there are interventional options currently under development, like the renal denervation, which uses the RFA probe and denervates the kidney, the sympathetic supply, and also the carotid massage pressure. familial diabetes, risk management. Familial diabetes requires continuous medical care with multi-factor risk reduction strategies beyond the control. So it's not just the glycemic control which has to be taken care of in diabetes, but there are other factors. The management plan should be formulated as a collaborative therapeutic alliance between a patient and family, the physician, and other members of the healthcare team. The management recognize the role of diabetes self-management and on ongoing diabetes support as integral components of care. So, what are the steps in the process of diabetes self-management? It is just a cycle which has to be told to the patient to follow. So they should assess themselves and they should set a goal regarding what should be their glycemic control and what are the dietary and physical goal settings. Then there has to be adequate planning, implementation, and there has to be always a close monitoring and evaluation whether the self management is adequately done or not. This eat smart is just okay. Coming to familial obesity, the treatment of familial obesity should also focus on changing health behaviors to achieve effective weight management. There has to be lifestyle modification as to reduce sedentary lifestyle and reduce junk diet, and also to increase exercise. The anti-obesity drugs which are of use now are the centrally acting serotonin or noradrenaline reuptake inhibitor. Mainly increases satiety, that is sibutramine. Pancreatic lipase inhibitor that reduces fat absorption by partially blocking hydrolysis of dietary triglycerides the orlistat, and selective antagonist of cannabinoid T1 receptor. The drug is rimonabant. Pharmacotherapy contribute to the reduction of body weight and improve cardiometabolic risk factors. Patients who benefit from anti-obesity treatment are those with BMI more than 30 or 27 to 29 BMI. Pharmacological therapy is complement to the behavioral strategy aimed at changing of a person's lifestyle. So extreme obesity, only bariatric surgery can be effective, but after adequate once the patient is adequately counseled, and patient has to be started on all other therapies before directly taking him for bariatric surgery. Thank you.